Hello, everyone. I'm Siri Vaith, Executive Director of Cystic Fibrosis Research Incorporated, CFRI, and I am really pleased to welcome you to our third question and answer series on COVID-19 and cystic fibrosis with Dr. Rick Moss. It is Wednesday, April 8th. This is an incredible time in our lives. There's so much uncertainty, so many questions to answer, and information is changing really rapidly. So we hope to continue to be your partner in keeping you informed. And I really want to thank all of those of you who submitted questions this week to ask Dr. Moss. I want to remind people CFRI has many programs providing support and education, so please go to our website, cfri.org, to see those resources. And as always, I have to remind you that the information presented in this recording should not be used for medical advice, diagnosis, or treatment, and that you should always consult with your physician before making any changes to your medical care. As I said before, it's Wednesday, April 8th. It's important to note that because the information is changing so rapidly. And so if you're watching this recording later on, some of the information may have changed. And now on to the questions. As always, I'm honored to welcome Dr. Rick Moss here to answer the questions for the session. For those of you who haven't watched any of the previous recordings, Dr. Moss is a preeminent CF researcher and clinician, former director of the CF Center at Stanford, professor emeritus at Stanford, and very fortunately for CFRI, a member of our board of directors. So I'm happy to turn the screen over to Dr. Moss. So we will jump right into the questions, and we always start with the first one. What is the current report for the US on the number of cases and fatalities?
Well, the United States has emerged as the world center of this pandemic in recent weeks, and that's not changing. In fact, the gap is growing. We now have over 400,000 cases in the United States. And as of this morning, over 13,000 deaths. That's an overall statement, but there's very wide variability. In a huge country like ours, we have a great variation between certain states, certain counties, certain regions. At this point, some of the biggest hotspots remain New York City, which has the bulk of the cases, but also other major cities. Some of the cities on the West Coast that experienced this early, like Seattle and San Francisco, went into early measures and actually now are showing signs of flattening the curve substantially. So that is a very hopeful indicator. There is a 2 to 4 week lag between the data that you see on any given day and what the reality of the situation is. And that's because of two things. One is the lag between exposure and symptoms. And the other is the lag between an onset of symptoms and fatalities or hospitalization for the more serious cases. So it's a rolling picture that emerges only with time, and that's one of the sources of some confusion and why these models are so important. Now estimates from various models project the peak in the United States to occur either sometime in the next week to 3 weeks. So this is going to continue to look worse for a while before it starts to look better. But again, think about that lag time as a factor there.
So since last week, have there been any other known cases of individuals with cystic fibrosis diagnosed with COVID-19?
I haven't heard of that. I do think that this is not something that, given the scope of the situation, you're going to pick up because of the relatively few number of cases, unless it gets onto social media. And we know that certain cases have appeared either in the mainstream media or on social media about some people with CF. And so far, they seem to have done well. I haven't heard of any fatalities in the CF community yet, but that doesn't mean that that's not going to happen. One thing that is interesting and relevant is a report that did come out from the CDC just 2 days ago on April 6th, focusing on children. And children, as many people have noted, are less affected by this in terms of getting sick. There have only been a handful of deaths in the United States in kids below the age of 18. But one thing I did want to mention coming out of that report is the fact that the highest risk factor in children was pre-existing lung disease. That was the #1 comorbid condition in the pediatric population. Now, most of those were cases of asthma. Again, reflecting the fact that for every person with CF, there's probably 100 with asthma. So it's a question of the population as a whole. But it does indicate that the CF community remains probably at the highest level of risk, ahead of cardiovascular disease and immunosuppressed, at least in terms of that CDC report.
Someone asked, if you have COVID-19 and are sick at home, when do you know that you should head to the hospital? I'm terrified that if my child is sick, I'll wait too long. Are most people needing to call 911?
Well, I am hoping that in the CF community, everyone has a connection to their CF center and certainly to their primary care providers. And what I would say to that question is, you should be on the horn to your CF center or your primary care physician's office before you head to the hospital. Because one thing that they want to do is to screen people remotely. And there are a number of reasons for that. One is to reduce the risk to the community and to healthcare workers, as well as to the person and their immediate loved ones. So the first thing to do is make some kind of contact, whether it's through telehealth or the phone, and get a remote assessment. And oftentimes, that's all it's called for. And treatment can begin at home. So I think that's very important. Luckily, the symptoms seem to come on in a fashion where you don't have to call 911 or rush to the hospital. More commonly, those situations arise with people that already know that they have COVID-19 and are starting management. So in that situation, if you're developing respiratory distress, obviously then you may need to get to the emergency room. But what we don't want to do is stress the emergency rooms beyond what they already have to do and use them appropriately. So I think good communication is the secret to this question.
I read about Great Britain's Prime Minister being hospitalized after being sick at home with COVID-19 for 11 days. Is this the usual course of the disease, that it gets worse after that much time instead of better?
Yeah, that raises a number of issues. Obviously, he's probably the most high-profile case at this point, but it's not atypical. We know that the time from exposure to symptoms can be anywhere from 2 to 14 days. And so he had onset of symptoms. Then the question is, what's the length of time that you can be sick? And in that case, it can be 14 to 21 days before you need intensive care. So his course is not atypical at all. And thirdly, those that are already in the hospital, many reports are of people who seem to be stable for several days and then suddenly deteriorate. So nothing about this is very surprising, unfortunately.
Boy, the more you know, the more frightening it sounds. I think you have the sense with most diseases, you get to day 11, you're kind of through the woods. But
this is a longer deal, yeah, and that's another way it's not like the flu.
Right. I read that in China, Europe, and states where COVID-19 cases are tracked by gender, women are more likely to survive COVID-19 than men. Can you explain why this is?
Well, I think the data are pretty clear at this point that men do worse than women if they do get sick. That is true. It seems to be the case in all the areas where this data has been generated. The answer, though, is not clear. And people have proposed several things. One is that it's already known that women tend to have a more robust immune response to viral infection than men. And so that's based in biology and some kind of gender difference there. But also one has to consider things like behavioral things that may differ between men and women. Rates of smoking are higher in men, rates of alcohol use, some comorbidities. So there may be environmental and social factors also. But the short answer is we really don't know, but that does seem to be a real difference, that men are at higher risk if they do get sick.
Wow. So in line with that, can you discuss the disparities in survival by race? I think many people have seen yesterday how African Americans are much more likely to die. Certainly, I mean, there are certain states population-based, it seems evidential, but is there anything else?
No, it is true that the number of cases in African Americans and the number of severe illnesses, the proportion is higher, out of proportion to their representation in the general population. So again, the reason for that is not clear. Part of it could be biological. That's certainly, there's no real information on that. But there are certain comorbidities that we do know are more frequent in African Americans, things like hypertension, which is known to be an independent risk factor, diabetes, obesity. These are all things that are overrepresented in the Black community. And the other thing is their access and levels of insurance and access to healthcare are inferior because of past and present discriminatory practices. So I think there's a mix of things, and what's really driving it, it may be a complex mixture, or there may be one factor that emerges and it's just too soon to know, but it's a real phenomenon, unfortunately. And I think this is probably going to get worse as the disease moves into certain areas of the country, like the South, where these disparities may be more prominent.
And where there are states that are not having the same types of precautions put in place to help.
Right. Exposure risks are also not evenly distributed in the country, that's for sure.
Are there any updates on ventilator or medical equipment rationing for those with CF?
Again, this is primarily a state or regional issue with big variations. I do know that the situation in California is such that early action by the state government has resulted in enough foreplanning so that the fears of lack of equipment, in particular ventilators, have so far not emerged. And in fact, as of today, I believe, California is sending some ventilators to New York. So that again sort of illustrates the importance of acting early and getting adequate preparations. So this is really a public health issue. On the other hand, equipment in terms of personal protective equipment continues to be a problem. This is one reason the CDC has recommended, in terms of the mask situation, for people to use their own homemade masks so as to spare surgical masks, and especially the N95 respirator masks for healthcare workers, where there certainly are shortages continuing in many places across the country. And this came out in the Health and Human Services Inspector General report, which the president trashed. But in fact, this is based on interviews with hundreds of different facilities around the country, simple facts of the case.
Yes, so it should not be voluntary, people. And you probably should use it. I have to say, I'm loving this surge of sewing groups that are mass producing masks to distribute to the general population.
It's really been great to see, in general, the tremendous response to that, and people, on the whole, are acting responsibly. The issue is that you have to try and push for 100% to really crush the curve. We can flatten the curve with partial cooperation, but we cannot crush the curve without complete cooperation.
Right. And hopefully it will become trendy to have your mask on, and people will feel more awkward when they don't have one on. I mean, I think that's
pretty nifty. I've seen some really interesting stuff.
With all the talk about ventilators, can you clarify the difference between supplemental oxygen when somebody needs a bi-pap in the hospital or when somebody has a ventilator?
Sure. So remember when we talked about the disease, the main problem in this disease is the fact that the virus attacks the air sacs and prevents oxygen from moving from the air into the blood. So what you have to do then is to give supplemental oxygen. And there are various ways to do that. The easiest way is simply to use a nasal cannula or mask device. And people can do this if they have that prescribed at home, but in general, if you need oxygen, you're usually going to be admitted to the hospital to receive oxygen therapy. Technically, you could do this at home if you had an oximeter, a device to measure the oxygen level. And I know this is happening in some places in New York, for example. People are given oximeters to use at home and monitor their oxygenation, make that contact if the oxygen level is falling or persistently below the usual figure they give is 94%. So then you're in the hospital, you usually start by just getting oxygen simply. And that can be given through a low flow device like a nasal cannula. The next step would be to give a higher flow, which definitely requires hospitalization. And oftentimes that works, but if it's not working, then the next thing to do is to give some pressure with the oxygen to help sort of push it into the blood. And that's where these non-invasive devices like nasal CPAP can be helpful. Unfortunately, in many of those cases, there's also an issue with blowing out enough carbon dioxide. So besides the lack of oxygen, people start to have trouble expelling the carbon dioxide that builds up in their blood. And that's a sign of impending respiratory failure. That's when people get intubated, because then you can use the intubation and the ventilator to exchange that gas for the person and let them rest. And so those are the various levels of support. Usually, oxygen by itself doesn't require ICU care, but by the time, and in many hospitals now they're using step-down units or wards to deliver non-invasive ventilation like CPAP. But if you need to be intubated, you need to be in the ICU, and obviously many people in that situation need to be sedated or even paralyzed. So it's a frightening situation.
And how do they know when a person is not expelling enough carbon dioxide?
Well, you'd have to usually get an arterial blood gas to make that determination. So it's a blood test, and that would be done in the hospital.
Got it. Got it. And are there signs when that's happening that would trigger that test? Is it, people disoriented? Are there?
Yes, disorientation, fatigue definitely are part of that picture. Confusion, those are all signs of retaining carbon dioxide going into acute respiratory failure.
Got it. Got it.
Luckily, only a very small fraction of even hospitalized patients get to that level. But since we're talking about a disease which affects the entire population in terms of lack of immunity, the absolute numbers, as we mentioned before, over 400,000 now. And that doesn't represent all the cases. There are many cases that are not diagnosed either by doing well or dying at home. So most people think that you have to add at least 10 or 15% to that number to actually get the true number of cases that are out there.
And my own question, it's not on the list, but with the issue of testing, I mean, isn't it 1 out of 4 they're saying could give a false negative?
It really depends on the test that's used, and not just the test itself, but how the test sample is obtained. It's not an easy thing to get the sample because you have to get a nasal swab and stick it way back in the nose, and it's not pleasant. At Stanford and several other places, people are working with self-administered techniques now where you just brush the tip of the nose near the nostril, and that's looking very promising. So my colleague, Bonnie Maldonado at Stanford is hopefully finishing up a paper now which will show that this may be an alternative that could be widely used, which would make a huge difference if people could self-administer the test and it was reliable.
Right.
The actual technology to detect the virus is pretty well established and probably very sensitive, although again, it will vary depending on the specifics of the test as well as how the sample was obtained. So no test is perfect, you're right. And there are people that will be a false positive or false negative. Very few false positives, but a substantial number of false negatives.
Which has such scary repercussions, right? People who think they are virus-free.
Yeah, and with ease of testing, again, if we're able to do this repeatedly, that would be helpful also, because somebody could be negative on Monday and positive by Wednesday. So that's something that also complicates the situation a bit.
Let's see, somebody said last week you mentioned that Facebook page with over 100,000 clinicians from around the world sharing anecdotal information and scientific information to help guide care models. Are there any new insights or information since last week?
There's something happening almost every day. I tend to get most of my information just by looking at specific websites that represent medical journals or certain organizations. The Facebook page is some kind of mix between good information and gossip and chatting, like everything else on Facebook. So you have to take what's on there with at least a grain of salt. But it is useful It is restricted to physicians and physician assistants. So it does give a flavor of what's happening around the country and indeed elsewhere in terms of how people are faring, what they're up against, as well as the things that they're doing. So it's not something that I would take as the gospel truth, but it is a good reflection of sort of the social impact of the disease on practitioners, which is helpful in its own way.
Yeah, yeah. I heard that coronavirus can be killed at 75 degrees Celsius, which is 167 degrees Fahrenheit. Isn't that a lot hotter than most home water heaters? And as such, how do I sanitize my clothes? I'm very nervous about bringing the virus home to my loved ones through my clothing.
Yeah, that's a kind of a complex question, because that gets to this issue of how much danger is there in objects that might be fomites, that is, places where viral particles might have been deposited. You know, we're all limited by practicality. So using the hottest cycle on your washing machine is probably the best you can do with clothing, and then also a hot, long cycle on your dryer. That information was really generated not specifically with COVID-19, but it's very close relative to the SARS virus. Studies there showed that, in fact, 70 degrees centigrade, which is about 160 degrees Fahrenheit, is adequate to kill that virus. So likely that is adequate. And if you have a cycle of time involved with a washer and a dryer, you're probably fine. Even healthcare workers have to do that when they're heavily exposed. And for most people, if you're exposed, it's going to be to a much lesser dosage, let's say, of the virus. So things like washing and drying, I think, are going to be fine. So I wouldn't get too worried about that, as long as you take care to do that with your clothing when you're out, after you come back in after being out and about.
Just don't wear the clothing you know is going to shrink. Just save it for when the snow over, right?
Other considerations.
Oh, here's that. I live near the coast and believe the salt water has done much for my CF health through the years. Now I hear that the beach and ocean can be a dangerous place for surfers and swimmers due to the aerosolizing of coronavirus in the waves. How afraid should I be? I hate to give this up.
So this whole issue of being outside is interesting. You know, I live in San Mateo County in Northern California, and the county has closed the parks and the beaches, and this has occurred in a number of places in California and elsewhere, I'm sure. And the reason for that is really more in terms of density of other people rather than the environment itself. My feeling about if your beach is open, my feeling is that it's very unlikely to be a source of a problem because of the fact that you're in the great outdoors. Even if there's some kind of virus there from somebody else, there's a time factor when they left, and there's the major factor of diluting that inoculum into this gigantic world-sized environment. So personally, I wouldn't have any hesitation about using the beach, going surfing, being there. I'd pay much more attention to how many other people are on the beach and how close I am to them. That's really the key feature. And the reason that the public health people take these measures is to avoid people not doing the recommended distancing, which is to maintain at least 6 feet. Aerosol studies do exist, but those are in closed rooms without the breeze, without diffusion into the environment as a whole. And I really have very little concern about being outside as long as I make sure I keep that social distance, physical distance from other folks.
I think you just made a lot of coastal dwellers very happy.
Surf if you can.
Let's see. Are there any updates on testing for antibodies of those who have recovered to know if a person is then immune? I saw that Finland will begin testing 750 randomly chosen people each week for coronavirus antibodies to better understand the spread of the outbreak. Will this be happening in the US beyond the town of Telluride? Question mark. And I don't know. Yeah. Telluride is what you mentioned before, right? That they're doing this.
I did, yeah. And the answer to that question is it already has. Not just Telluride, but right here in the Bay Area, Stanford had launched a serology or antibody test I think there are about 3,000 people involved in that over the last weekend. They put an announcement out and they got, 10 or 20,000 people saying, me.
Right.
They were only able to do enough testing for several thousand, but that's a good start. I'd make two more comments about that. One is that blood banks in the United States and in fact internationally have begun sampling blood donations to look for whether or not there's whether or not there's antibody that's been developed in any of those donors. Now that's a skewed population because to give blood, supposedly you need to be healthy, right? So that would be looking at truly asymptomatic general population to get some idea of whether or not there's any immunity out there. And that's important work. But we do need these more focused antibody tests in localities where the entire population is looked at, both asymptomatic as well as symptomatic. Obviously, people that are sick need to be tested, both as soon as they recover and later, to look at how long lasting that might be. So all those things are ongoing. Those studies have been initiated, and we should get some information from that fairly quickly. Second thing that's relevant to that is that, again, over the last few days, a paper was published from China where they took blood from people that had recovered from serious illness with COVID, took that blood and processed it to make plasma, and then gave the plasma to people that were severely ill, critically ill. It's a small study, but they had very, very good responses. The virus was shut down and these people recovered very quickly. So there's, I think, a lot of hope there that antibodies can be very useful. And besides using plasma, companies can make a form of gamma globulin from that plasma. And even beyond that, other companies can make what's called monoclonal antibodies that are directed specifically at the virus and specifically where it attaches to the cell. And those things should be available not in the next few weeks, but in the next few months. So that's a very hopeful sign.
That is really exciting, especially with the vaccine they're anticipating at least a year, correct?
Yeah, this may be a very crucial interim measure that may be available later in the summer to use this kind of antibody therapy for people who are either sick or at very high risk of getting sick.
Wow, a game changer. That's
very important, yeah.
Exciting. That should be our lead. If I'm not diagnosed with COVID, but coughing, would inhalation therapy of albuterol or Xopenex be helpful or harmful?
I don't think there's any evidence that it's harmful whatsoever. And in fact, there may be some benefit. People are using albuterol as part of the COVID support, at least in some patients. And of course, people with CF use albuterol a lot. So this may in fact be helpful, but I don't think there's any strong data on that. My own guess is that it may have some benefit, and I don't see any reason that it would be harmful.
A lot of known friends and family members are still getting together within their homes for study groups or healthy hangouts. Can you address this? If isn't that what quarantine? This contrary to all notions of quarantine, right?
Yeah, unfortunately, some places recommend no more than 2 people together, right? So it would be hard to enforce beyond that, but. The larger your group goes, one of the key factors now is this whole idea that you may be infected without knowing about it, asymptomatic or pre-symptomatic, and therefore you may be exposing others. One of the disturbing things that's come out about the very high rate of disease and death in Italy and Spain is the fact that they have a different social structure. Unlike the United States, it's very common for children to be living with their parents, and I'm talking about adult children with their parents. So you may have a 50-year-old and their 80-year-old parent in the same household. And there's increasing concern that it's this social factor which has led to the severity of the problem in at least those 2 countries. They really do have more of a family together lifestyle. Mm-hmm. So if you take that lesson, it really is important to try to avoid unnecessary congregations of people. The use of masks may help. And I don't know if these little hangouts involve people wearing their masks in, in the privacy of the home. But every little bit can help. I would say you should try not to do that to begin with, and try and rely on technology to get your social needs met, which of course is difficult, and everyone's, we're all under the same gun of not liking that, but I think that's the safest thing to do.
Is it safe to walk, run, or bike outside with others that are not living with you if we keep a 6-foot distance? And should we be wearing masks while we are walking, jogging, or riding bikes?
I would say yes and yes. I think that we need to maintain our health by all means, and exercise is one of the most important. This is especially true for people with CF. So you got to continue doing your exercises. And if you're wearing a mask and you're staying away from other people, at least 6 feet, you're pretty safe. I think the risks are extremely low, and the benefits outweigh any risk involved.
Great. What are your favorite sources for accurate information about COVID-19?
Well, I rely a lot on the journals. So, as a professional, I can look at things like JAMA and New England Journal, The Lancet. They basically become COVID-only journals in the last month or two. And they're literally getting hundreds to thousands of articles every week. So that's a huge fire hose of information. For the general public, I still think the CDC website is probably the single best place to go. It does get updated and changed. The mask situation is a perfect illustration of that. It's not like we know everything now. Things are going to keep changing, but that is probably the most authoritative and most trusted site. I actually think that the main media outlets, and I'm thinking of the New York Times, Washington Post, Wall Street Journal, CBS, the networks, and CNN, I think have been very reliable in terms of their information. So I think those are all good sites. The other thing I would say is, depending on where you live, look at your county public health website. That's extremely useful. They often will keep a tally of the local situation and also update the recommendations from the CDC. And oftentimes some of these counties are ahead of the CDC in terms of what they're recommended. That certainly was the case both in California as a state and San Francisco and other Bay Area counties in terms of the social distancing measures, which have been effective in flattening the curve here.
Yeah, I guess Los Angeles, the mayor said everybody should wear a mask prior to the CDC recommending it too. So
many instances of that, and one can be on both sides of the equation there. There are other places where they're lagging. Mm-hmm. So I wouldn't say it's universally true, but in many places in the country, the county and the state websites are also quite helpful.
Great. Let's see, if we have CF, should we consider taking hydroxychloroquine and azithromycin prior to getting COVID-19?
This is a tough one because there's so much about this in the media and on social media. I would say no. I think that the evidence on hydroxychloroquine is lacking and very thin. There will be more reliable information fairly shortly, because there are some trials that are properly designed, ongoing right now. Remember that hydroxychloroquine is needed by people with other chronic illnesses like lupus and rheumatoid arthritis, and some of those people are having trouble getting hold of the drug. Number 3, hydroxychloroquine has many side effects. A person that I think is one of the leaders internationally in epidemiology is a guy named Dr. Larry Brilliant, who was responsible largely for the eradication of smallpox. And in the course of his career, he got malaria several times and had to take hydroxychloroquine for his malaria. He said every time he took it, it was worse than the disease in terms of side effects, which can be fatal also. It can produce cardiac arrhythmias, liver failure. So it's not a benign drug, and it has not been proven. The other component of that is azithromycin is, of course, something that over half folks with CF in this country already use chronically. So in a way, if the general population is glomming onto azithromycin, we may have trouble having access to it for people with CF who really need it. So overall, I would say, no, don't do it. Wait for better information.
Great. I think we have come to the end of the list. And so now I ask you, is there any final advice you'd like to share? Any final thoughts for viewers?
I think we've covered a lot of good things. There's only one thing that I would like to mention, which I've sort of become more interested and aware of in this whole situation, and that is the distinction that somebody made between viability and infectivity. This relates to this whole issue of coughing, droplet, aerosol, depositing on things like clothing, surfaces, food cartons, packages you're getting, things like that. You may be able to detect virus, the genetic material of the virus, and it may be viable, but it doesn't necessarily mean that it can cause disease. And part of that has to do with dose. And there's more and more people are writing about this now, that whether you get sick and how sick you get may involve the density of your exposure, the dose of the virus you're exposed to. So it's not just whether it's there or not. It's not simply a plus minus issue. It's also a how much issue. And that's something to keep in mind as you think about things like going to the store and buying groceries or changing your clothes, how frequently. All these things have to be thought of in terms not just of whether you may get any exposure, but whether that exposure is significant enough to cause disease. So in a way, I think one of the issues behind physical distancing is to reduce not just your exposure to any, but also reduce the amount of a dose that you might get exposed to. That's one reason to wear the mask, so that if you do carry, you're not putting out a large dose into the air. So that would be the only thing that I would add. And to me, that means that we don't have to be quite as paranoid as we think we are when we're dealing with this situation.
And also just a reminder, I mean, we all have to act as if we have it. And if we all act that way and put those protections in place, we can flatten the curve.
That's right. The safest thing is to think that I am the problem.
Yeah. Yeah. Well, once again, I thank you so much for sharing your time and your expertise with the CF community. This is just such a gift, and you are helping keep us all informed and alleviating anxiety, and we are grateful. So thank you.
Thanks and good luck.